Yes, I've been asked to speak about patient and family-centred care rounds in ICU. I'm just going to talk a little bit about why we would even think of this being outside the flags. This is the session. It's called Outside the Flags. And just what we do know and what we don't know, and perhaps just a little bit about moving forward. So why would we even think it's outside the flags? If you just look at the little the sign there, it says no swimming between the flags, it's dangerous. So not always being between the flags is the best place to be. I'm just wanting to speak a little bit about how we can reconceptualise the care that we give and the focus that we give, and move away perhaps from what we realise and think of as safe, usual and familiar practice. I think universally we actually are a little bit resistant to change. Many of us perhaps would like the fact that change happens, but then when we're asked, we're perhaps look at the bottom part of the cartoon, we're one of those people. Someone yesterday in one of the presentations, one of the people in the audience asked a question and they said, yeah, it's great when we're asked to do things, but what if our leader is the one that isn't the one who's going to change? So this is a universal thing. It goes across all of there's a hierarchy, doesn't change whether we embrace it or not. Some people are perhaps a little bit more feel empowered to do it, but we acknowledge, I think, that it's not easy to do something different. And why do we talk about this now, about a new, I don't say paradigm, a new way of trying to embrace patient and family-centred care? I think we recognise perhaps that the community is expecting to be able to be more informed and to be empowered in their healthcare. This has been driven, I think, both by international and national standards, where we're acknowledging the fact that families have an enormous amount of impact in the intensive care when they're allowed to and when they're supported to it. The emphasis on patient family-centred care and thinking about them in rounds is the emphasis on meaningful engagement. And what I mean there is that it's not only when we want to speak with the families, but actually it might be when they want to speak with us. So we might have family conferences which we call, or we'll go and speak to families when we want to, but I'm thinking more about the meaningful engagement from their point of view. And the other reason to be speaking about it, I think, is that perhaps they're not universal. Just around the rooms, can I ask how many of you have families routinely in your multidisciplinary rounds on a day-to-day basis? Okay, so that's 3, and I know you're from the US. So that's another reason to speak about it, because it is not universally accepted. And we perhaps don't want to be all like the feldspar in the cartoon. As I mentioned, we have national standards, and these are quality and safety standards, and there are 10 of those that every hospital facility in Australia has to meet for accreditation. 7 out of the 10 require us to partner in some way with consumers, and that means patients and families. Partnering with patients and families is clearly represented in international clinical guidelines in Australia, in the US and also in the UK. We do have a lack of patient family-centred care outcome measures. We're all perhaps quite used to those that are infection rates or length of stays, but maybe we might be missing the point a little bit when we're talking about from the patient and family's perspective, when we're trying to evaluate, trying to incorporate patients and families in rounds. It's always very important that we understand the obstacles. We've heard about translational research and the implications that we might know that the knowledge is out there. Some of us are still working on the knowledge, I think most of us are, but even when something is quite definite and conclusive, it might be that there is still some site issues where it makes it more difficult to implement. There's some national guidelines that have just been released this year, and that's been led by Judy Davidson from the US, and this is published in Critical Care Medicine. And it's guidelines for family-centred care in the neonatal, paediatric and adult ICU. So it's quite embracing these particular guidelines. They have made 23 recommendations, and one of them I have there, and it's looking at ICU family-centred care recommendations. We suggest the following. The terminology we use perhaps in guidelines is really important, so they say suggest. That tells us that the level of evidence they have for this is very low levels of evidence. But albeit that's the case, 1.2 says family members of critically ill patients should be offered the option of participating in interdisciplinary team rounds to improve satisfaction with communication and increase family engagement. Development of these guidelines, there were 29 key stakeholders who developed them. They updated the guidelines which were originally written and published in 2007. We all know that our attitudes and perceptions are one of the greatest influences of our behaviour. This 2014 Canadian study looked at they did a survey and looked at the attitudes and behaviours of the intensive care staff in their 24-bed mixed ICU. So it was mixed medical surgical ICU. There were 160 in this survey who responded, and they were looking at both medical and nursing respondents. 37% of the registered nurses agreed that family members should be given the option to attend. 37 in this ICU. However, there were 70% of the doctors thought that the families should have the option to be present. When we looked down, when the researchers who published this looked down a little bit more and looked at the characteristics, they found that it was the experienced nurses who were more hesitant to have patients and families there for their ICU. In fact, it was double the number of experienced ICUs. There were 60% versus 25% strongly disagreed that families should be given the option. So it perhaps tells us a little bit about when we are experienced, and maybe we go back to that slide earlier where we do hesitate to change. Perhaps what was certainly even more concerning for me was a letter to the editor that was in the following edition, and this was published in the Intensive and Crit Care Nursing in 2014. So it was following the letter, following the publication of the previous study. And the writer of this, after initially praising the researchers for their elegant study, they made suggestions on ways around the issue. And I'm actually going to quote to you what they said when they wrote in this letter. One opinion is to encourage more patients to take out advance directives. Family members are only on the ward rounds in the first place because they can act as surrogate decision makers. But if the patient has already made the decisions in advance regarding common and important management options, for example, cardiopulmonary resuscitation or prolonged ventilation, then the family surrogate may not be required. So it was an elegant study, but it's an elegant study as long as we keep families out of ICU. So I thought that was, what in my certain perception, really quite worrying. But let's just have a little look at the evidence that we have when the studies that have been done that have looked at families being involved in rounds. So one of the perceptions is that it will take longer. It will take a lot longer. The research we have that has looked at this have been drawn from our paediatric colleagues. There are 3 there's probably more than 3 paediatric colleagues. There are 3 paediatric studies that have looked at this, and each of them have found no significant difference in the time it's taken for rounds when family members have been there. One of the studies, they went from 13 minutes to 11 minutes, non-significant. Another one went from 10 to 9, not significant, and so forth. What they did find was a significant reduction in the post-round family meetings, and they went from a mean of 5.3 to 0.3. So this was a significant reduction. It did not take them longer to do the rounds, and there was a significant reduction. They also found that the family knowledge of the clinical course and plans increased from 35% to 87%. That was in a study by Allen in this year, 2017. And they were looked at 412 family members The other area where people feel that there's a problem with having family members there is that there would be a reduction in the capacity to teach at the bedside. So can traditional teaching continue? A 2007 study by Phipps and his colleagues measured the time spent in teaching in a prospective study of 105, once again, paediatric intensive care admissions. There was no difference in the amount of teaching time with these 105 paediatric admissions. Interestingly, I thought that family members asked questions 28% of the time. However, the medical staff asked questions 32% of the time. So the medical side asked more, because sometimes I think the perception of the time is that the families are going to ask more questions and that will take more time. The other outcome from this particular study was that the authors thought that when the junior doctors or even medical students were there, when the families were there, it allowed their experienced colleagues to demonstrate what it's like to communicate and to gain information and communicate effectively and partner with families. So they thought that there was an added benefit, and this is from a study that was operating with patients' family-centred rounds. So they thought that gave an extra opportunity, that they learnt from very beginning that family are a resource. They want to be involved in decision-making to varying levels and varying degrees, and they therefore perhaps are less worried about it when they go into becoming more senior roles. The other thing is that there's a perception that it's going to be anxiety-producing or increased stress or confusion for family members. This also has not been found to be the case. In the 2017 Canadian case by Allen that I've mentioned before, it found that 38% of ICU staff estimated that there was a moderate interest by family members. 38% thought there was a moderate interest, whereas when we asked the families, 97% of them expressed a high interest. And then when they asked the staff whether they thought it would cause stress for the family members, 22% thought it would be stressful. However, 7% of the actual family members thought it was stressful. And 30% of the staff thought it would make them confused. 0% of the family members thought that they would be confused by being included in family rounds. Both family members and the ICU staff reported that listening and sharing of information was an absolute positive that resulted from it. The other perception that comes from the literature is that there's constraints delivering negative information and that there's the potential for legal risks about what's said. There's been 2 studies that have looked at this, and in one of the studies, a paediatric study, 98% of the families did not report any privacy concerns. There was only 81 family members in that study, so obviously that's a relatively small study. And in the other study by Barnwell, they reported 20% had some concerns about the privacy issue. They did also report, though, that the risk of being overheard they thought was outweighed by the fact that they wanted to be able to communicate and get the information and be able to participate in the information sharing. I do suggest also that with the ICUs we are going, there are more ICU units that are working towards private rooms. There are a number of instances that our very closest big public hospital has completely private rooms. And there are other ways to manage it if we can ask people from neighbouring rooms or neighbouring bed areas to move out during rounds. So there are ways, I think, that privacy can be managed. The concern with litigation, when you delve down into the reasons we are litigated against, it is very often the fact that it is to do with ineffective communication. So when there is effective communication and respect for the reporting team, the percentage or the risk of legal risks is relatively insignificant. Just one other report from one of the studies was that family members presented that the improved perception of the intensivist compassion listening, and they showed greater respect for the family member. So just a summary looking at the perceptions and fact and fiction. So family presence at rounds will slow the rounds down. That has not been found to be the case to date. Family presence will decrease the quality of the teaching. Also has not been validated in the literature. Family members do not want to be included in the rounds. Fiction. Family presence in rounds is anxiety producing. We did find that there was a small percent, but the majority of families would prefer to be present. And family presence increases legal risks. Largely fiction I've written there. We need to manage confidentiality, as is the case now. So the unknowing is a powerful thing and often generates apprehension, worry, fear in all of us, and whether we can cope. In Alan's recent study in 2017, just this year, it shows that if we improve patient and family knowledge and whether we knowledge about what we're able to do with them when they're there, and some of the things that they looked at was the satisfaction that they had. So when this particular study, the nurses' satisfaction when family-centred rounds were introduced, beforehand, they rated it 18% of their satisfaction with it, and once the study had completed, that rose to 98% of the nurses. They found that the family knowledge and clinical course, so the understanding that the family members had about their families, the goals of therapy and the clinical course, that was increased from 35% to 85% once families were involved in rounds. So a significant improvement in those areas. So I've just got there, replacing fear of the unknown with maybe curiosity. So sometimes, and I mentioned yesterday in another presentation, when we have projects brought into units, sometimes it's a nice modulated way to introduce things for people to get some degree of understanding and support, and then maybe the project idea can be dropped off and it can just become usual practice, and people perhaps could embrace it a little bit more easily then. Our paediatric colleagues also lead the way when we're talking about family-centred rounds, and they've even spoken about and done studies about ways to improve them. So they've been doing them for a long time, but they're also now trying to improve them. And one of the things that they wanted to improve was actually to focus back onto the purpose of the round, and that is to advance the care of the patient. They also wanted to improve the efficiency of the round. In that the impetus for this particular study was that the rounds were taking a long time. They were blowing out, excuse the colloquialism. They were extending to something like 2.5 hours when they were used to having them quite a lot shorter. So they restructured and reconfigured the rounds as they were progressing, and they developed and assessed whether a plan of care was operational, and they assessed the communication, and they assessed the length of time. These all showed that they were able to make improvements once they refocused what the purpose of the rounds were. Measuring endpoints that are relevant are important to all research. We're obviously very familiar with the high precision and high accuracy that we have in some of our, able to target some of our endpoints. Length of stay is great, infection rates are really easy to perhaps to count. Longer term patient outcomes such as quality of life and cognition following ICU are also possible. But when we're thinking about something about family-centred rounds, it's perhaps a little bit more difficult. We don't actually have any scales that have been validated to assess this. Perhaps we need to be thinking about what's important to families. What are they? I mean, is it that they want to know about the plan of care? Is it that they want to be able to communicate and hear what the interdisciplinary team are saying? So thinking about what it is. A little quote that I found that I thought was perhaps quite insightful was we forget what people say, we forget what people do, but we are less likely to forget about how they make us feel. Sometimes those things are difficult to measure, though, and qualitative research is frowned upon in some areas, in that it's who cares what one person feels. But I think when we consider the number of ICU patients we have in beds, they generally, many of them have families. So it's, there's lots of people out there who are genuinely affected by what we do and caring for their patient. So many organisations and individuals, we do struggle with change, and I think one of the important things is that there's no quick fix when we bring change in. One of the talks yesterday was citing the literature that says once things are quite definite and organised and published and absolutely work, it then takes 17 years for that to come into practice. So quick fixes don't work. They do need commitment from the whole interdisciplinary team. Remember that the study I mentioned a bit earlier, it was only one study that talked about the nurses being the ones that were more negative to it. But, you know, I wonder what you'd think about was the case in your ICU. So I'd just like to finish by saying, remember that swimming between the flags is not necessarily the safest place to be. Thank you.